67-year-old male who was diagnosed HIV positive in 1999 with a baseline CD4 count of 46 cells, baseline viral load 83,000, subtype C, past Hep B, Hep C negative, started antiretroviral therapy in 1999 with AZT3TC and indinavir. This is his treatment history. So starting from October 1999, he had increased transaminases as well as low-level viremia up to 400 copies when he started. And as you can see, the CD4 count was very low, 38. He was then changed to AZT3TC and abacavir, but his liver disease progressed. And in fact, he had a liver biopsy at that time, which showed the evidence of incomplete septal cirrhosis and active portal and interface hepatitis, which was attributed to the AZT in the regimen. He continued to be viremic at that time. Let me see if I can, yes. So he was then changed to abacavir, 3TC and efavirenz, and experienced a high-level viremia, CD4 count 117 at this point. He was then changed in 2001 to tenofovir, D4T, 3TC, and Calitra. Do you remember that? For those who are old enough to remember that. Not me, of course, but some of you in the audience, right? So he developed lipodystrophy at that point, but hey, he was suppressed, and the CD4 count was now 256. Then, of course, we became modern at some point and decided to move on to dual PI regimens. You remember those ones? So tenofovir, atazanavir, and boosted fossamprenavir. And on this regimen, between 2004 and 2008, he experienced low-level viremia up to 600 copies, but his CD4 count was holding at 349. In 2008, he then moved on to tenofovir, raltegravir, twice daily darunavir with ritonavir, and again continued to experience episodes of low-level viremia, but this time up to 200 copies. He also had some evidence of renal disease and started to complain of poor memory, but of course he was getting a little bit old. Anyway, his viral load was suppressed at the last assessment available here, and his CD4 count was very good at 447. Okay, so that is history. This is, if you want to look at it by looking at his viral load, you can see that he had a long period of good suppression below 50, but then he started to blip, if you like, blip, but also having sort of persistent low-level viremia on the regimen. This is not, yeah, let me see if I can get this to work a bit better. So he started to experience this low-level viremia first on the 2-PI regimen, and then more recently here, while he's on tenofovir, raltegravir, boosted darunavir with ritonavir. Okay. So, of course, he had resistance tests during this time. The first one was done at the time of the failure on AZT3TC and abacavir, when he had in reverse transcriptase a few times 67, 70, 215Y, and 219R, as well as the M184V selected by 3TC. So quite good going resistance, but not all is lost, of course, in terms of NRTI activity just yet. He then had a failure on abacavir, 3TC, and efavirenz, and predictably he developed some more resistance, abacavir resistance, L74V, and also had 2 NNRTI mutations, 100I and K103N, all pretty much predictable at that point. Okay, so what happens now? He's bleeping, so he's having drug resistance testing at this point. He's having viremia, not very high, but nonetheless he has 2 resistance tests that at this point show no evidence of RT resistance, but he has a mutation in the protease gene, which is 32I at this point. Okay. Right, so now you have been given yes and no, or pro and con cards. Please, now, use those, okay? I don't have mine, but I'll vote. So I will first give you a list of management options, and then I'll ask you to vote. Thank you so much. Thank you. All right, so these are the cards, yeah? So green or red. So there are 4 possibilities here. We could address any psychosocial issues that may be impacting on adherence, overall factors contributing to adherence, continue to monitor given that the viral load is still below 200 copies. we may request more investigations, we may decide to change or intensify his ART regimen, or we may want to talk to the lab or perhaps look at the way the clinic is taking the sample to see whether there may be some technical reasons to explain the low-level viremia. Okay, so I'm going to ask you to please vote on the first option. Who would like to continue to monitor having assessed adherence and factors that impact on adherence? Okay, there is an overwhelming green and a lot of people who are not going to vote for this at all. Okay, right. Who will request more investigations? Okay, may I please ask what would you request? Okay, so we have a drug therapeutic monitoring. Of course, this is a drug interaction talk, so that is well placed. Sorry, you said? Okay, we have a CSF analysis as well. Okay, let's hold on those thoughts. Who will, at this point, change or perhaps intensify, so add maybe one other drug to the regimen? Okay, I will say most people will not actually, with few exceptions, will not do anything to the regimen. Would you like to say what you will do? Those, Danilo, you voted for a change. Quick comment about what you will do?
I think that adding to do the tropism determination and adding Maraviroc can be useful.
Okay, so we got there, yeah, a preposition to consider Maraviroc. Yeah, that's a possibility. Okay, now what do the guidelines say about what do we do with these patients? Certainly we need to address adherence, tolerability, and psychosocial issues that may impact on adherence, as circumstances may have changed over time. We may want to look at the technical issues surrounding sampling and viral load testing. We know that the way perhaps the sample is stored before testing may impact on the occurrence of low-level viremia. We know that different tests perform differently, so we may want to have a look at that issue. We want to, of course, review the overall expected potency of the regimen, and as we sort of, we're talking about drug-drug interactions, we may want to think about the possibility that the patient may have added other drugs, perhaps prescribed by the GP, perhaps taken over the counter, that may impact on drug exposure, and any sort of potential food requirements of the regimen which may not be observed. I think it's reasonable to perform resistance tests in these patients. It's reasonable to perform drug levels, drug concentrations can be measured. I think it's also informative in these patients with persistent low-level viremia to think about the CD4 count, nadir, and the pre-ART viral load, because we know that these two parameters have an impact on the likelihood of detecting low-level viremia, at least in some patients, because, for example, they may give you an idea about the size of the HIV DNA reservoir, which may impact on both on occurrence and detection of low-level viremia, and also it may make you think about some compartmentalized virus replication. So I'm not going to go into the details of that because of time, but the relationship between these parameters is rather complex, because we may have subjects in whom the viremia is explaining is explained by ongoing virus replication, which may be causing both low-level viremia and also continue to replenish the reservoir. It may be that the advanced immunosuppression, very low nadir CD4 counts, is favoring the compartmentalization of virus replication, which again may allow ongoing virus replication. And also, simply having a large reservoir, regardless of whether there is ongoing virus replication at present, may favor the occurrence of short-lived bursts of virus replication that may be detected as low-level viremia, and also, particularly with some viral load assays, may increase the likelihood of detecting the DNA in plasma by picking up the DNA as an RNA signal. So some tests are prone to doing that. So those are all the factors we may want to think about. Okay, so some more data about the utility of doing resistance testing in these patients, and also the utility of measuring drug levels. This is a study from Canada. Just the summary of this is that they looked at the first sample of the low-level viremia and asked whether the drug concentration, PI or NNRTI, and the presence or absence of resistance to the drugs the patient was taking, so the activity of the regimen, the genotypic sensitivity score, were predictive of the likelihood of then experiencing a rebound above 1,000 copies during follow-up. And as you can see, we have up to 3 years of follow-up, and during that period, there were 3 independent predictors of rebounding above 1,000 copies. One was having suboptimal drug levels, one was having a GSS less than 3, so fewer than 3 active drugs, and one was the level of the low-level viremia itself, with patients having more than higher sort of levels, particularly more than 750 copies, having the greater risk. But as you can see, all levels of viremia between 250 and 750 increase the risk of rebound per se. And having low drug exposure also meant that the development of resistance on low-level viremia occurred more rapidly. And I think it's interesting that we've had some discussions this morning about the resistance to dolutegravir and the fact that some patients have experienced the emergence of resistance, particularly in the sailing study, which was a study of patients that were integrase naive but treatment experienced, and they received dolutegravir 50 milligrams once daily, together with a regimen chosen by the treating clinicians and based also on the resistance test results. And there have been a few failures in this study with integrase resistance, and I think what's interesting to see is that there were 2 patients that actually developed a mutation which is not the dolutegravir 263 mutation, but rather was the more like a raltegravir-like mutation, the N155H. So this was integrase naive patients that actually developed on dolutegravir a raltegravir resistance profile. Many explanations have been proposed, but one that I think is quite interesting is the fact that drug exposure in this patient was very low. And I'm just wondering whether the level of dolutegravir exposure may modulate the resistance pathway to dolutegravir, and perhaps where the level of exposure is low, an easier resistance pathway may emerge, such as N155H, whereas perhaps different levels may push the virus towards the less favorable resistance profile, which is the 263. Anyway, this is just speculation. Okay, let's go back to the patient. Here is where we are. So we did the resistance test. Interesting at this point is on tenofovir, raltegravir, darunavir, ritonavir twice daily. There is no RT resistance. There is no protease resistance at this point. And I should add that one of the 2 samples was also tested for integrase resistance, and there was no raltegravir resistance at this point in plasma. Okay. The concentrations of darunavir were in range for a virus which at that point was considered wild type. All right, so we keep going, we do more resistance tests, and again, there is no resistance detected, although the episodes of low-level viremia continue. So now, you've seen all of those data, you've seen what's happening in follow-up. Have you changed your mind? Would you request more investigations than what we've done? We've done the resistance testing a few times, we've done drug levels. Would you now do anything to the treatment regimen? Okay, let's start. Who would request more investigations? Okay, right. So, which investigations? Dan, what would you request? You change your mind now.
No. So I think clinically I would do nothing differently, but this becomes a very interesting research question. So at this point, what I would do is single genome sequencing from limiting dilution PBMCs, because there are quite a few of these kinds of patients who are being seen, and in at least some of them that's well documented, they have clonal expansion of a wild type provirus from cells that are releasing virus.
Virus from reservoir.
I mean, the best described is the one from Alderelli.
Yeah.
We have one in Boston now that I've heard about recently with a couple of thousand copies, fully therapeutic drug levels for all of the drugs, and persistent viremia in the 1,000 level. And they're now doing exactly that kind of investigation. And
you think that the simple Sanger sequencing here is picking up wild-type virus because these other viruses
I think I think what's happening is there's an expanded clone of CD4 cells that harbors the wild-type virus, which is releasing virus.
So that's the wild-type that's been released. Okay. Any other comments at this point? Yes, Linus.
Well, In that case, the protease should still inhibit that if it's a wild type.
There's no replication. That's the whole thing. It's not replication. It's virus production and release without propagation.
Yes, it's going back to the model that we said, where you could have a larger reservoir without having active virus production, which is pumping up virus intermittently because it's large enough that you then pick up substantial viremia. So that is certainly a model that applies to some patients. But of course, is this the case? That's the question.
I mean, of course, Mardarelli has this one patient published by Simonetti. The patient died, and I mean, this one patient that is described, so it's very limited.
Yeah, I mean, I think the difficulty is that I think there are quite a substantial number of patients that reflect that, and some don't. So I think the clinical challenge is to understand which are the patients that don't fit that profile.
And I think that's been mentioned before, but a lumbar puncture to look for a separate clone would also be interesting, I think.
Okay. Any other comments? Still going for the CSF sampling? Any other comments? No? Okay. Right, so we did take a CSF sample. And interestingly, the viral load in the CSF was actually higher than we found in plasma at 2,000 copies and 5,000 copies in 2 subsequent samples, taken quite well apart because the patient traveled in between sampling. Okay. Comments? Okay, so we want a resistance test on the CSF, says Francesca. Okay. And drug levels in the CSF. Okay, anything else? And tropism in the CSF. Okay, so resistance test, drug levels, tropism in the CSF. That's the shopping list. Money, no objection. All right, so let me just tell you, first of all, this patient had a CSF sample. We would have done it now, but at the time he went into a study that we were running where we basically analyzed patients that had a history of low-level viremia and took a sample, a pair sample of plasma and CSF to see whether there was a discrepant viral load. So he was one of the patients we studied. And interestingly, when we compared patients that in a larger study that had no history of low-level viremia but were undergoing lumbar puncture for a number of different reasons and had durable plasma suppression, we compared them with patients who had a history of low-level viremia. We found that the proportion, which was, quite significant, had actually a discrepant result between the plasma and the CSF. So here is the sort of very quick summary of the study. So there were 43 subjects that had durable suppression for at least 12 months on ART and 40 subjects with a history of low-level viremia. And out of the 43 with stable suppression, none had HIV RNA in CSF, whereas 9 of the 40, or 22% of those with the history of low-level viremia, had a discrepant HIV RNA in the CSF at quite, as you can see, quite substantial levels. Now, this is all very interesting. I don't know whether you can really extrapolate this prevalence, across wide populations, but I think what was really interesting from the study is that we could find a significant association between the nadir CD4 count and the likelihood that there was a discrepant CSF result versus plasma. There was also an association with black heterosexual exposure group, which may perhaps also be linked to the fact that this population frequently has a low nadir CD4 count, perhaps, I don't know. But anyway, there was no association, friends, pharmacologists, with drug concentration or, in fact, with the CP score in the CSF, I'm sorry to say. Okay, right, so resistance test in the CSF, the drug levels were done, there was nothing really to write home about in the CSF, but the resistance test was quite interesting in the CSF. These were the results. So these are the 2 samples tested with identical profiles. The tropism is R5. The RT has exactly the same mutations as this here, this virus here. And interestingly now, there is also resistance to raltegravir, with selection of 66I and 155H in the CSF sample. Comments? Yes, lots. Okay.
So I think this is really a great example of compartmentalization, because I think it's a very plausible explanation for why you have persistent virus in the CSF, but I bet if you did a phylogenetic analysis, you'd find that the CSF virus is not what you're detecting in the periphery. So you don't really have, there isn't yet convincing evidence that virus that persists in the CSF in this scenario actually reseeds the periphery.
I completely agree. I think you're looking at compartmentalization of replication and virus evolution. In fact, phylogenetically, the virus we sequence from plasma is actually not the virus we sequence from the CSF. I think that this goes back to what Francesca was asking earlier, whether perhaps what you have here is a situation where patients who experience very profound immunocompromise, very low nadir CD4 count, perhaps very fibrotic lymphoid tissue, as well as neurotropic virus with compartmentalized replication. And perhaps the low-level viremia may be explained by suboptimal activity in lymphoid tissue, whereas the CSF is reflecting, you know, the same type of issue, but not necessarily seeding the plasma. That is sort of an idea that could explain this. All right, so now we're going to have to treat this patient. So, ready? This is what I sort of a menu of options. We got boosted darunavir with dolutegravir and etravirine. You got the same, but with maraviroc, or perhaps with both maraviroc and etravirine. Would you add tenofovir, or perhaps TAF plus or minus FTC? Which dose of dolutegravir would you use? What are the considerations we need to make? Okay, right, so let's start. I'll give you now the not knowledgeable overview of the pharmacology. Questions, please ask Seku. All right, so impact of ARVs on dolutegravir exposure. What do we need to know practically as a clinician to make a decision here? I think what we need to know is that some of the drugs have a negative impact on the exposure of dolutegravir overall. Particularly, I would like to draw your attention to the fact that darunavir does reduce exposure, although normally this does not require an adjustment of dolutegravir. But remember that we are now in an extreme case where we're going to have to optimize exposure to dolutegravir as much as we can. So we need to keep in mind there is a little bit of an effect of the darunavir, but if we were to consider using etravirine, we need to anticipate that there's going to be a hit on darunavir exposure, which may be in part compensated, will be in part compensated by the use of the boosting PI there, but still will mean that there is an interaction that has an effect on dolutegravir exposure. Of course, I will refer you to the website, so I don't have to give you the answer myself, but if you do that using the website, this is what you will find. It will be a number, which means caution. If you were to put in all of those drugs, so we are looking at dolutegravir, TAF, emtricitabine, etravirine, and ritonavir, and maraviroc, of course. Sorry, I think the thing has shifted a little bit. There's maraviroc as well. If you were to look at the, you will have a number. Basically, what we know is that there is going to be an interaction between etravirine and maraviroc, which reduces maraviroc exposure. So you need to adjust, but if you have the PI on board, you can still use maraviroc 150 BID. In fact, the ritonavir has a boosting effect on maraviroc, as we know. The website will also tell you that there is a potential interaction between ritonavir and dolutegravir, which potentially could somewhat reduce the exposure to dolutegravir. And as we said, there is an interaction with etravirine that tends to reduce exposure to dolutegravir, in part compensated by the use of the PI. Okay, so these are all the complicated things that we need to think about. So here I'm thinking etravirine. How much is it adding in terms of activity? Patient has 100Ni and K103N versus how much may be taking away from exposure. Okay, what else do we need to think about? If we want to maximize exposure, we may want to think about the dose. We know that we can go up to 100 milligrams BID. Now, this is a patient with raltegravir resistance, 155H. We will normally use 50 milligrams BID, but remember we can go up to 100 BID. We know that there is a dose exposure proportionality. The more you give, the more active the drug is, up to 100 once daily, I think the study indicate. We know the half-life is 11 to 12 hours, and that if we want to maintain high exposure, we need to give the drug BID. And what about food? We know that normally we don't need to worry about food. However, we know that food will increase exposure to dolutegravir. So if we are in situations where we want to maximize exposure, we may want to recommend our patients to take dolutegravir with a meal. Okay. This is the slide showing you the relationship between dolutegravir plasma concentrations and the activity, basically showing that the average plasma concentration significantly predicted virological responses, with low exposures translating into reduced responses. Okay. What about other special considerations for these patients? Remember, he has a impaired renal function. We need to think not so much about pregnancy, with this man, of course, or children. We don't need to worry, but certainly the possibility of renal impairment having an impact needs to be taken into account, particularly is also getting older. And there is no dose adjustment required for dolutegravir, but something which I find quite interesting and I cannot explain is that patients with severe renal disease tend to have reduced exposure to dolutegravir. And I'll stop here and ask my colleagues, pharmacologists, whether there is any new explanation about that finding. Say, Giovanni, Charles. Yeah, I mean, you know, just Giovanni's got the answer. Yeah.
God only knows. I mean, you know, the funny thing regarding severe renal disease is not, we don't know why the DTG exposure is going to be reduced. There is around a 30% of renal elimination. I don't know why, but it's unexplained, actually. So what the other point of the question you would like to ask?
No, that was the point,
no,
really.
No.
Yes.
I think is that if you go on the Liverpool website and you look at the paper, there is no explanation for this.
There's no explanation.
It's just a clinical report.
Okay,
it
so
should
we
be
don't
repeated,
know.
I think. It should be repeated. I wouldn't trust such a document 100%. It's just
Okay, so, but at the moment, what is the recommendation? Is that you don't need to dose adjust because of renal impairment. However, you need to be aware that if there is severe renal impairment, your exposure may be going down. And so if you are in a situation where you need to maximize exposure, you may need to take that into consideration.
Yeah, no, I mean, exposure in such a case is going to be measured, I think, because you also took into consideration the possibility to use unusual doses like 100 milligram BID.
Exactly.
So in general, it's better to gain experience of this extra dosage and then have the data.
Okay. Right. So that's what we need to think about for this guy. What else do we need to think about? He's getting older. He may be getting worried about his poor memory. He may go to the chemist, the pharmacist, and pick up drugs off the shelf to try and boost his memory, or perhaps feeling to try and feel younger, take some multivitamins. We do need to make sure we caution the patient about taking antacids, for example, or products that may contain cations, aluminium, magnesium, calcium, or ferrum, because iron, because they reduce the absorption of dolutegravir, and they need to be separated relative to the assumption of dolutegravir. So we need to counsel the patients about that. Okay, this is just a slide to show what happens with cations, such as magnesium or aluminium containing antacid. They do reduce the area under the curve for dolutegravir by 74%, so big impact on absorption. So it's important to really counsel patients carefully about this. Same for calcium supplements, for iron supplements, multivitamins, whereas there is no negative impact of omeprazole. What other things we need to worry about? I don't think we need to worry about oral contraceptives for this man. Should he take ranitidine or cimetidine? I think it's okay. There will be no dose adjustment necessary. But I think we need to start worrying about perhaps metformin is getting older, and his GP may start him on metformin. So important to write to the GP, to be in contact with the GP about the fact that the maximum dose of metformin in patients taking dolutegravir should be 100 milligram a total daily dose, and that if we ever then stop dolutegravir, we may need to readjust the dose again. And certainly the recommendation is to monitor blood glucose, both when starting concomitant use of metformin and dolutegravir, and if we stop dolutegravir. So that's another practical consideration for clinical use. Okay, so we're coming to the end. I'm aware I'm sort of between you and lunch, of course. So we are going to make a decision based on all the various issues that I've told you about is favored treatment. So those are the options. So can you please vote? Who will go for boosted darunavir, dolutegravir, and etravirine? I don't see enthusiasm for this particular one. What about darunavir, dolutegravir, and maraviroc? I see moderate enthusiasm for this one, but certainly enthusiasm. What about both? No, some people are definitely no on that one. Okay, I think I've done a good case there with the drug interactions things. Thank you very much. And of course, the decision was indeed to use darunavir, dolutegravir dose twice daily, 100 milligrams twice daily, and maraviroc 150 milligrams twice daily, of course, with close monitoring, as Giovanni has also recommended. Now, what about the use of tenofovir, as TDF or TAF in this patient? Can I ask who will add that to the combo? So give me a green for adding. No. And a lot of people who have really undecided. Do you want to comment on that?
I have a witness here. And I said from the beginning, this patient should take also FTC.
FTC?
From the very beginning. I don't, we did not know about this CSF issue, but I would have given it in any case, because even if it's some remote sanctuary, I think that the residual effect of FTC could have been significant, especially in the context of low-level viremia.
Okay. So, any other comments? Yes?
You ask about tenofovir, not FTC. It's okay for lower fitness.
Tenofovir and FTC, or okay. TDF and FTC. Yes.
Okay, but TDF, of course, not, because of interaction on renal function. It's an older man. It's with diabetes. It's of course not tenofovir here, and it is not going good in CSF also.
Okay, so I'll just repeat that okay. for everybody. So the considerations being made here are that we wouldn't like to use TDF because of the renal issue. We may consider TAF instead, but however, the penetration in the CSF is not brilliant. Is that a summary of any further comments on that? Right, so who will add FTC? Let's take a vote on that proposition. Who will add FTC alone? Dan, do you want to say why not?
So I'm more despite the caveats that were just mentioned, I'm more taken with the idea of adding TAF. So I would add TAF FTC as the combo, because you can't get TAF by itself. But and first of all, TAF is approved for use in the U.S. to creatinine clearance of 30.
Yes.
And secondly, it's really the higher intracellular concentration of tenofovir diphosphate that you're going to achieve with TAF, which may have a beneficial effect and even overcome resistance. That's still hypothetical, hasn't been proven clinically, but in this situation where you're trying various desperate moves, I think it's worth a try.
I agree. So my own perspective was that I would have consider TAF because of the renal rather than TDF and FTC, but particularly because I think of trying to overcome that resistant virus that's got several TAMs plus an M184V, and TAF may actually have increased activity, at least in vitro, seems to have a better activity than TDF against virus with TAMs. So that is a consideration. And of course, as we said, is there any comment about using 100 BID here of dolutegravir? Does anybody feel that that is an overkill? Or overkill. So some people say that's an overkill. There is a 155 mutant in the CSF. I'm just making sort of the case here. This patient has already got virus replicating the CSF where, we don't think that darunavir is already on darunavir BID and has been for a while, and it doesn't seem to be having any really significant impact, or at least not substantial suppressive activity in the CSF. So we don't want to leave this patient just on maraviroc and dolutegravir. Well, we like not to, hence the consideration around FTC and so forth, but also we would like to protect that integrase a little bit more. That's why, if tolerability is not an issue, the dose was increased. Yes, Jose.
Yes, a great case. 2 questions, Ana Maria. Your expectation with this regimen is the low-level viral rebound in blood will go away? And the other question is what will be the endpoint? You are going to need to LP the patient again?
I would say that, yes. Because I think the low-level viremia is probably originating from a different mechanism than the different source.
We're talking here about a cellular reservoir and an anatomical reservoir.
Possibly,
right?
yes. Or even if the lymphoid tissue is fibrotic, that could actually per se be an anatomic reservoir of sort.
It's just a comment. In such case, in my hospital and the hospital of Diane, when we want to have a very high concentration of dolutegravir, we boost dolutegravir with adding atazanavir, 150 milligram, only 1 pill, and it provides higher concentrations than when we use dolutegravir 100 BID.
Yes, that is very true.
So in all cases, we do that.
Yes, we saw in the previous slide, that's a very important other consideration. We saw in the previous slide that, in fact, atazanavir has a booster effect on dolutegravir. So that's another consideration.
Ana Maria, last burning question. You put there darunavir boosted. To get levels into the CSF is equally using cobicistat and ritonavir?
So you mean whether they were measured?
No, I'm saying you said that darunavir boosted. You are not saying if with cobicistat or with ritonavir. Does it make a difference?
It's ritonavir at the moment because it's BID.
But my question is, it will make a difference to get levels in the CSF?
You're asking me whether boosting with cobicistat will increase?
No, I'm asking the pharmacology.
Well, I mean, let's ask the triumvirate there at the... Well, so I'll repeat the question. If we were to boost darunavir with cobicistat, will we get better activity in the CSF? I mean, in the CNS? Because we do get levels. I mean, we got good levels in the CSF, so the levels of darunavir are good. So the question is whether we will improve activity in the CNS.
Okay.
No is the answer.
No. The thing is that, listen, there are very few data about the darunavir level on CSF, regardless of their importance, the intrinsic specific weight of having or not having enough drug exposure. Really the best exposure you get is 600 milligram ritonavir twice daily.
600 milligrams
darunavir plus ritonavir twice daily.
So twice, which is what we're giving. Yeah.
We made a comparative study, a small one in Torino, and there's a much lower exposure in case of 800 milligram plus ritonavir. We didn't have a copy at that time, but presumably it's going to be the same. I mean, so this makes a difference. You have to be careful. I mean, deciding what to do with the darunavir. Is it going for 600 milligram twice daily, or
yes,
it makes a change in CSF?
Yes. So I mean, we're continuing the same. Yeah, we need to close. Yeah. Just to conclude, the worry here is that even at that dose, we're not seeing activity of the darunavir. Even so, right. Thank you, and particularly a thanks to Sekou for the slides, and David Beck from the slides, and also Romina Quercia from Vivo for some slides. Thank you.